you. And thanks very much for a very warm introduction. It's lovely to see you again, Lesego, and thanks very much. Most of what he said is totally not true. I'm not that good, but let me try and tell you what I do know. So actually the topic I was asked to talk about was a little bit of a slice of PrEP. So really looking at Cabotegravir particularly, because I think many people know about Truvada as PrEP, so either that or one of the generics, but this is really a new kid on the block, and it's important to know some of it. Now I know you've had some of the evidence shown to you at a previous seminar of this. So really what I want to do is to cover the nuts and bolts of what we think this drug will be able to do, where it will work, where it won't work, and just so that you're aware of it as it's coming. This drug is famous overseas and is being processed locally through SAPRA, so it may pop on the market anytime soon. And if it does, I really do think it's something to know something about as PrEP, because there's many advantages to this this drug over the current standard of care. So let me just go through some of it, and then we'll take some questions at the end. So we know that oral PrEP is good. We know, so this was pioneered by Truvada, and of course now with generics, and also overseas with TAF-containing regimens as well, also approved. So this is really a combination of tenofovir and emtricitabine usually, which is kind of, it would work the same, we think, as tenofovir and 3-TC, let's say. And when you take this as pre-exposure prophylaxis, and you take it well and you take regularly, you can achieve a very high degree of effect. It seems to work a bit better in men than women, and it's unclear whether that's just slightly better adherence with the populations that were studied, but there may be something else to it as well. We know that the drug does get into the genital tract a bit quicker in men than in women, and so it's a bit more forgiving of suboptimal adherence. So there may be biological reasons why it's a little bit better with men than women. That jury's a little bit out still. But you're looking at efficacy over 90% in MSM, men who have sex with men populations, and in heterosexual men and transgender women. A little bit lower in people who inject drugs. And in women, there's much less data. We do have now data from a number of places around the country and elsewhere in Africa as well. And it suggests that the efficacy here is probably about 20–30% lower. So you're dealing with efficacy, depending on the trial that you look at, in the 50s, 60s, and 70s% on average, although there's obviously a lot of variation. But the big thing it depends on is adherence. In other words, if you take it consistently every day and you can plot this, you can measure the drug levels in a trial setting and see how well the people with high drug levels do compared to the people with low drug levels. And the low drug levels are they're low because people are forgetting to take their medicines. And it really is quite dependent on that. So that's one downside of this. And I certainly don't want to knock it in the slightest. This is a good therapy. This works well. It saved lives. It saved people getting HIV, and it's not something to knock at all. As Lesego said, there's 2016 guidelines. There's actually 2020 guidelines now on the HIV Clinician Society website that they updated. And you really should have a look at that, because that's available right now. And we don't do it well in South Africa. We don't offer this well enough and broadly enough to as many people as we should. And who should take this? Well, pretty much anyone at risk of HIV, which in this country is a lot of people. If you don't have HIV and you're sexually active, you are at risk of HIV, and you should at least be considering it. And obviously, there's some groups who may benefit slightly more than others, but in essence, if you want it, this is something you can take. And it's safe and it's effective and it works really well. But it's so dependent on adherence. And I don't know about you, but if you've ever been given a course of anything, you've gone to somewhere where you need a malarial medicine, or you need a course of antibiotics, or you need a course for anything, or even your chronic medicines, if you're diabetic or hypertensive or something like that, the adherence that we demand of our HIV patients is, and in PrEP for the HIV negative, is so much more than we demand of everyone else. Diabetics don't take their medicines as commonly as our HIV patients do, but that's a problem. Once daily medicines is difficult. People have hectic lives. They may come in and out of risk depending on their social circumstances and personal lives. This is, so there's a hole still here. And there's a hole particularly for women, because their efficacy does seem a bit less, although again, it's probably, in my opinion at least, because it's a bit less forgiving in women than it is in men in terms of the genital concentration of the drug. So there is a gap. And we also know that in real world settings, this is a nice systematic review that was done in 2020. Now, just to talk you through what this is called a forest plot. Basically, this vertical line here means, well, in general, actually, this is the average in this case. So it looks like somewhere in the 60% of people are defaulting basically within a month of starting. Now, this is a number of studies. You can see some are more, some are less than that, some are more than that. But 66% of people discontinue the oral PrEP within a month of starting in a lot of these studies, many of which are implementation studies or slightly more real world settings. So in practice, even though this drug works, again, the problem is getting people to stick on it. And it's not easy because, again, it's a daily pill that you have to take. Many reasons for that. Side effects of the medicines are one, although the side effects are not huge with PrEP. They can be enough that people, if they get even a mild headache, remember you're HIV negative when you're taking these medicines, so you have a far lower threshold for tolerance for side effects. Pill burden and pill size, it's not a small tablet. And of course, it's a daily tablet you have to take every day. And then there's obvious health system issues and stigma, which applies for every form of PrEP. If you're taking a medicine to prevent HIV, then there's a certain stigma to that too, because people start asking about why you need it, for example, which is a ridiculous thing, but which really does add to the stigma of trying to prevent HIV. So this is a lot of people discontinue, we know this. So where does Cabotegravir fall into this in terms of PrEP? Well, it's an integrase inhibitor. So like raltegravir and elvitegravir, which we don't have in the country, but which is overseas, and dolutegravir, which we clearly do have, and which is the focus of our antiretrovirals. Cabotegravir, and you can see by the ending, is an integrase inhibitor, so it works the same way as the others do in theory. And this busy slide really is just to show you, remember, of the life cycle. So here comes the HIV virion. It binds to the cell. Oops, sorry, it binds to the cell. It effectively gets endocytosed. It gets taken into the cell, and the envelope gets rid of. And effectively, then you move from the RNA, which is inside the HIV, to reverse transcriptase. Because remember, normal transcription is DNA to RNA. This is backwards. This is RNA to DNA. So reverse transcription to DNA. And then the DNA gets integrated into your own DNA is in that cell. And that's quite unusual for viruses. Very few viruses integrate anything into your own genome. They usually sit outside here in the cytoplasm or sometimes in the nucleus, but they don't usually add themselves to your own genome. And that step is by integration, and that's integrase, the enzyme that catalyzes that really. So integrase inhibitors are preventing that step, this integration into your DNA. They're a very effective class of drugs, clearly. We focus most of our antiretroviral regimens around them. So that's how they work. All of them work that way. But the big thing and the interesting thing about cabotegravir is that you can have an oral therapy. You can have oral cabotegravir, although that's practically only used for the lead-in for the injectable, which I'll talk about in a second. But it's been formulated in a different way as an injectable. And it's done as a nanosuspension. It's a tiny molecule effectively, but whose pharmacokinetic properties allow it to have a very, very long half-life. So if you inject this intramuscularly, the half-life is somewhere between 5.5 to 11.5 weeks. That's, in other words, the time it takes for the drug concentration to halve in the blood. And so most drugs have half-lives measured in hours, not days, let alone weeks. So this really does hang around a long time in the blood if it's given in this nanosuspension as an injection, not the oral form. We're talking about the injectable form, which is really the focus of PrEP for that. And that allows it to be given not all that common and not all that frequently. So in fact, you can dose it currently every 2 months. So every 8 weeks, basically. If you get an injection, that's enough to keep the drug level in your system high enough for that whole 2-month period that it can work. And cabotegravir has actually been studied both for prevention in PrEP and also treatment in combination with a long-acting form of rilpivirine. But today we're just going to talk about the PrEP aspect of this. But again, this is a key concept because it's once every 2 months, and that opens up a lot of options in terms of what you can and can't do for pre-exposure prophylaxis. So you have seen the trial evidence in an earlier study, in an earlier one of these talks. So I'm just going to whiz through the highlight of really these 2 trials. And they were conceived as kind of mirror image trials. So there's what they call HPTN 083 and HPTN 084, HIV Prevention Treatment Network number 83 and number 84 trial. And in the 83 trial, they looked at women, basically, men and transgender women. And then in the 084 trial, they looked at cisgender women. So, and really the results were very similar in both, but even women were even more impressive than in the men, which is a difference from, remember, the Truvada studies, where the TDF-FTC combination, the tablet, seems to work a little bit better in men than women. So this is exciting for a number of reasons, but let's just have a look at the one that was done in men and transgender women first. So it's quite a big study, 4,500 people. And what they did is something like, this is the kind of schema. So I just want to talk you through it because it does explain a lot and it's worth just spending 30 seconds on this particular slide. So all the participants were randomized to either get cabotegravir or Truvada, right? TDF-FTC. And so one was the injection, one was the tablet, basically. They first had an oral lead-in phase in the beginning for the first 5 weeks. And so you got then, if you were going to get cabotegravir, and remember you were blinded, you didn't know which one you're going to get. But if you were going to get cabotegravir, then you got oral cabotegravir, so the oral tablet, which remember doesn't last that long, but you can take it there. And then you got a placebo, and then the other arm got Truvada or placebo. So in either case, you get placebo. So they gave you a few weeks as oral medicines before the injection. Why did they do this? Well, in this study, they weren't sure about the side effects really of the injections. And if you inject something, it's something that lasts 8 weeks, then potentially the side effects last 8 weeks. And so they wanted to exclude people who had side effects by giving them an oral drug first. So giving them the same drug, but giving it orally in a short-acting form, and just to see. And then if they tolerated that, then they moved on to the injections. And if you were in the cabotegravir arm, you got your injections every, so there's week 5 and 9, so 4 weeks apart, and then every 8 weeks afterwards. And then you got oral placebo, and in the other arm, you got the reverse. You got Truvada and then an injection placebo. Can you imagine anything worse than an injection placebo? You don't even get the benefit, you just get sore. But anyway, that was how the trial has to be done for good reason. And they got this, so you can see where the injections occurred every 8 weeks, and they went all the way up to about week 153. And then for people who couldn't tolerate injections for whatever reason, like they just got side effects or they became pregnant, well, not in this case, this is the men study, the 084 was pregnancy, but then you dropped off and you got oral Truvada for a period. Why did they do that? Because this is another key point, is that, well, of course, if you're taking this injection every 8 weeks, it lasts a long time. But if you stop, it's going to take a long time for that to wear off completely. So you'll have a period after 8 weeks where the drug levels are lower than you want and lower, but they get lower slowly. So there's a long period where you get subtherapeutic levels, low levels, which the concern was may drive resistance. And we'll see whether that panned out as I go through the study. But that was the reason for this. So in essence, they're trying to study this big here. They're trying to say, oral tablets versus injection, but they've had to do it in a bit of a convoluted way where you start with an oral lead-in phase for both drugs. Then you have the injection versus oral phase with placebos on either side. And then if you end early the injections, then you end up in this pile where you get Truvada for another period of some 48 weeks. Okay, so it's a bit complicated, but the results are dramatic. So when they looked at this here, and let's look at this slightly zoomed up version. Here's cabotegravir, and this is the incidence of HIV. So in other words, the higher this graph goes, the more HIV there was. And what you're seeing here with cabotegravir is that all the way through to week 157, there were only a handful of cases. In fact, there were just 13 HIV, and this is out of thousands, this is over 2,000 people in each arm. And they only had about 13 infections. And it basically equates to 0.41 infections per 100 patient years. When you look over here at Truvada, they had 39 infections in the same period, which was 1.22 per 100 patient years. So that's a good way of measuring the time, because obviously people came in and out of the trial at different points, and they may have ended their trial participation earlier, or they may have ended the injections earlier. But basically, a good intuitive way of thinking of it is if there was one person taking it for 100 years, they would struggle to get an infection with cabotegravir, whereas they're more likely to get one with Truvada. And this was a median follow-up of about 1.5 years. And if you look at the side effects, lots of people appeared to have moderate side effects, a grade 2 side effects, but that was actually driven by a few things like a slight change in the creatinine clearance, for example, but there really wasn't a big difference. And none of these side effects were particularly worrying. When you get to grade 3 and above, still quite a lot, but most of them were injection-related side effects. Serious adverse events were about 5%. And then did you need to discontinue due to the injections? Very few. I think it was about 2% or so of this particular study. So the side effects, interestingly, were pretty well balanced. So whether you took Truvada and then a placebo, or you got Cabotegravir and a placebo, pretty much all the side effects were the same, and they're balanced out. They weren't really more with one than the other. The only exception to that's the injection. With injection site reaction, where if you got the active Cabotegravir, you did have more injection site reactions, but they tended to be quite mild. Very few people discontinued for that reason. And they also get better with time, which is interesting, and I'll cover that more in a second. Of those people who did get turn positive, because there's not a lot, remember, there's just 13 in the Cabotegravir group and 39 in the Truvada group. A few of them did get integrase resistance. Of the four people in the Cabotegravir group out of those 13, and that's something to look at, and we'll cover that in a bit. And then the logistics of implementing Cabotegravir programs warrant further study. So we're going to talk about the logistics a bit later, because that's another key point. So again, just to summarize, this is really one done in men and transgender women. And this seems to show over here, if I show you the hazard ratio of their 0.34, that's a cunning way of really saying that's about a 66% reduction. Oh, sorry, seem to be jumping around today. 66% reduction in the amount of HIV that the people got over 1.4 years in the Cabotegravir arm relative to Truvada. So Truvada is already a good regimen. Remember, we said, we showed how well it works, especially in men. And this is showing an unexpectedly massive improvement on an already good regimen. You've got about another 66% reduction relative to Truvada. Okay, what about the other study? This was done in women, and this was the first author here, Sinead Delaney Moretwe, who is actually a South African scientist, if you know her. She works at the WITS Health Consortium under the WHRI. And so very proud to have a South African leading this and doing so well and so impressively. But this was essentially the same sort of trial, but it was done in women. So it was done at around the same time, just the difference really was that it was done in women. Same sort of idea, you had an oral lead-in phase, then you got the injections or the tablets or versus placebo. And then if you ended early, in this case, it may be for pregnancy or for other reasons, then you got 48 weeks of Truvada to help with the tail while Cabotegravir levels were still coming down potentially. Right, so same sort of study design. What does it find? Well, it had an even more impressive result. And you can see again, remember, higher is worse. It means more HIV infections. And the blue is Cabotegravir. The red over here is Truvada. And you can see the difference. You don't even need to see the numbers to see how big the difference is there. And that really was about an 89% lower risk with Cabotegravir relative to Truvada. And again, Truvada is already not a bad regimen. It's a good regimen. We have it in the country. We should be using more of it. But this is an 89% improvement on that in women. And you can see here the difference really was 0.2 per 100 patient years versus 1.86, 1.9, let's say, with Truvada. So again, a big difference. Why the difference is seen, and again, the safety profile looked about the same, and the resistance was actually interesting. There were only 4 people on the Cabotegravir arm over here who developed HIV despite being on it. None of them, in fact, were taking their medicines right. They either had HIV at the time of enrollment, or they developed it during the oral lead-in phase, or some other problem. But this really does seem to work wonderfully. I mean, there are very, very few infections in this population group. Why? Why do we think the difference is? And in both these trials, they were able to do drug levels, and in fact, were able to be quite cunning about it and answer that question. And what you can see if you look at the Truvada levels is that the levels tail down as the weeks go on, because people just get sick of taking it. Even though if they tell you they get sick of taking it on the trial. Whereas with Cabotegravir, the levels that were regarded as therapeutic remained around 90% or more in almost throughout the trial. So it just means, again, that people were more likely to be adherent from the point of view of keeping the drug levels up. Truvada isn't that much harder to take because it's got to be every day, and people get tired of it or they forget. And it doesn't, for that reason, just something that you're going to get every 2 months just seems to be something which people are more likely to stick with. Again, these are clinical trials. It doesn't always reflect what happens in the real world. And you have to look at that and see how likely that is. And you can imagine some of the thoughts going through your heads about how likely this is in the real world. But it's worth just showing this massive, massive, massive difference in relative terms between the two. All right, so if we look at these again, if we look at, this is now the second trial in women, similar sort of idea, lots of side effects, but most of them were creatinine clearance related. And by the time you get to serious adverse events, it's only about 2%, and it's in both arms. So whether you're taking Truvada or Cabotegravir, about 2% of both groups had serious adverse events. There were a few more deaths in the cabotegravir arm, but they weren't related to the drug. It just seems like it was random. Just one person that, I think, a myocardial infarction or something, and others had other reasons, but none of them were thought to be related to the drug in that. So this is the conclusion from that trial. They said that although both products were generally safe, well tolerated, and effective, and that again is worth reminding people of. We know, again, it's not that I want to knock Truvada here, and not in the slightest. It's a good therapy. We should be using much more of it. There'll always be a place for it. It's just impressive, though, that cabotegravir did that much better than Truvada in the same kind of setting. So what are the sort of lingering questions? Why haven't we all rushed to do this? Why aren't we handing this out in every pharmacy and every clinic in the country? What have we still got to answer? What have we still got to think about? All right, and there are some things, because this data, whenever you see it for the first time, you think, wow, that looks fantastic. But then the more you think about it, there are some things that crop up. So let's address those, and then I'll take some questions afterwards. So one is the resistance. So the good news about cabotegravir is it's an analog of dolutegravir. I mean, analog, not that close. You can make some changes, quite profoundly necessarily, but it's got that same sort of high barrier of resistance that dolutegravir and bictegravir, for what it's worth, have. And so that's a good intrinsic property to have. But remember, we said it's got this long tail. So in other words, when I stop the drug today, because it's got such a long half-life, it's going to take a long time before the drug goes to zero. So for the first 8 weeks after stopping, we know it's going to be therapeutic because we can dose this every 2 months. But after that, it's going to be lower and lower and lower, but slowly. So you've got a long period where the drug level is low. So if we look at these two trials, what happened when that occurred? Because there were people who delayed their next injections or who dropped off. What happened in that case? And the good news is that there were only a handful of infections during the tail, not a lot at all. And none of them really so far had led to any integrase resistance. But again, these are small numbers in absolute terms. If we roll this out, not over a couple of thousand people, but over hundreds of thousands of people, you'd see quite larger numbers, and we'd be sure of this answer. But so far to date, the tail doesn't seem to be driving resistance. I mean, you can get HIV in the tail, obviously. That stands to reason because the drug level is low. But it doesn't seem to be generating integrase inhibitor resistance across the two trials that have really been done as these two big phase 3 trials. So that's interesting, because it suggests that our worry about the tail may be a little bit oversold. But again, time will tell. We'll get more information. We'll have more people on these regimens, and we'll follow them up for a bit longer and see. So that's one thing. Then the other thing which always interests people, and of course for good reason, is these breakthrough infections. So what happens if you're taking these so-called this cabotegravir, but you get an infection nonetheless? Many of them actually were found to have HIV at baseline, which is interesting. So in other words, you can't really blame the drug here. They had it at the time they started getting the injection. So in fact, in the oral lead-in phase. Most of the rest of them were associated with low or undetectable drug levels. So that implies, again, if you're not taking it well, in other words, if you space it, you're saying, I'm not taking every 2 months, I'm maybe missing doses, or I'm taking it every 3 or 4 months, when the levels are lower, that drove most of the rest of the HIV infection. So that's good news in a sense. And it means, again, that if you're taking it, those ones should be prevented. And then there's only a very small number of patients. So 4 of them in the male study and 0 in the female study, who got HIV despite what appeared to be good adherence. And they were measuring drug levels, so you could kind of show that the adherence was good. Of these 4, really, and the 4 down here on the bottom, some were associated with integrase resistance. And so, for example, this one here, number 3 and number 4 of those 4, both developed integrase resistance, but numbers 1 and 2 didn't. So 2 of the 4 developed integrase resistance. But all of them, whether they had integrase resistance or not, were able to be successfully transitioned to a different ARV regimen. And in many cases, that was a protease inhibitor-based regimen because of the integrase resistance. So you don't want to give dolutegravir necessarily, although depending on the mutations, you might still be able to, but in most cases, you'd have to move class to something like a protease inhibitor or an NNRTI-based regimen. So this is just really diving deep down into those few people who did get HIV despite what appeared to be therapeutic levels, but most of the rest of them had another reason which is much easier to explain, such as they had low undetectable drug levels just because they weren't taking the medicines well, or they actually had HIV at baseline and it just wasn't picked up until later. All right, so I hope that kind of gives you a sense of these breakthrough infections. Just again, I mean, this is 4 out of what was it, 3,500, 0 out of about 2,500. Sorry, it keeps jumping, sorry. And that is really quite low numbers in absolute terms. And the difference is quite a lot bigger with Truvada, but even with the Truvada, it's still quite low numbers. Both of these therapies work well. And it really is, you're dealing with a very small number of people who are going to get HIV just by taking their medicines. One very interesting thing, and it's something that's a practicality that we're going to need to think about more as this gets registered in the country, and as we start working out where to put it in terms of guidelines, and hopefully it's priced well enough that we can, and all these other discussions, which I'll come to at the end. One of the interesting things about this is that when you had breakthrough infections, mostly the viral load was so low at the time, and for a long period afterwards, because of how good these drugs are, that they didn't develop a good antibody response or even a good P24 antigen response. So these ELISAs, these kind of fourth generation ELISAs that we use as lab-based tests, or the rapid tests that we do, which are usually antibody-based, that you can do at your practice or elsewhere, many of them were negative. Actually, at the time, the patient was proven to be positive in hindsight when you did viral loads. And that's interesting because we didn't see quite the same thing with Truvada when you're taking the oral tablets here. And so it does look like if you're going to be monitoring people on PrEP for HIV infections, you're going to probably need to be doing viral loads, in my opinion at least, rather than ELISAs or rapid tests, because they were sensitive, you detected that early. But if you're waiting for the antibody, say, to kick in, or even the P24 to hit enough level that it triggers the fourth generation ELISA, it seems like people can be missed for several months, actually, despite having HIV. These people were well clinically because the HIV was very low, but it can obviously drive some degree of resistance if you're on monotherapy, obviously. So we want to detect these people earlier. It is interesting. We'll probably have to do viral loads rather than ELISAs or rapid tests if you're going to do this. But again, I can't speak for what any future guidelines may say, as I'll show in the end there. We don't know. This is just my opinion at the moment. The other thing to think about was the side effects. People always ask about side effects for very good reason. Like I said, the only difference between the groups was really that if you got cabotegravir versus placebo in their arm, you had more injection site reactions. That makes sense because the placebo was inert, cabotegravir isn't. And one of the interesting things about this is actually from the 083 trial, so done in men and transgender women, is you can see here how the amount of, this is the percentage of people reporting as an injection site reaction drops over time. So in other words, it does seem you get better at it. So the first injection, you get maybe half of the men complained of an injection site reaction, but by the time you go down, it's hitting sort of 20% or so. And that really does suggest something interesting. It suggests that you actually do get more tolerant of it, or the reactions get less severe as time goes on. The women, and it won't surprise the women in the audience, but the women behave better with this. They had complained less of injection site reactions. I think it was about 30% at the beginning and about half that by the end. So again, these are not uncommon, but they're usually mild. You can, and I'll give you some suggestions about how to monitor, how to manage them. People did also look for weight gain. And there were no statistically significant differences, but there were trends towards slightly more with cabotegravir versus PrEP versus Truvada. But again, this is a topic for another time, perhaps, but it doesn't appear that these drugs cause weight gain. They really just unmask it, if anything. So this is from the FDA, the Federal Drug Agency in America, who have approved cabotegravir already, which is why I say it's coming, and it's coming quickly. And they recommend for the first 2 or 3 injections, just take an over-the-counter medication. So, so take it a few hours before or as soon after as you can, and just take it for the next day or 2 while you've got this injection. So a little bit, it's a bit like our COVID vaccines, where you know you're going to feel a bit flirty and get vaccinated. You take some over-the-counter pain medicine, some Panadol or some Brufen or something, and you'll be fine. You can also apply a warm compress or heating pad to the injection site for 15-20 minutes after the injection. So like, for example, you could get the injection, come home, just put a warm compress on for a few minutes, and that also seems to help. And then you may need it with subsequent injections, but it seems to be, like I said, less and less common as time goes on. All right, so manageable almost always. I mean, a few people will have, if you're doing it to thousands of people, a few of them will have issues where it's bad enough, the pain, that they don't want to take it, fair enough, but that's quite a small percent. And I stand to be corrected, but I think it was about 2% in the study in men and 0% basically in women. Okay. What about some of the other side effects? This is taking the one from the 083, which is the study in men and transgender women. And you can see what sort of things people had. Now, the important thing here is you're comparing it not to nothing, you're comparing to Truvada, so Cabotegravir versus Truvada. And like I said, apart from injection site reactions, pretty much these numbers are the same on both sides. So it's not different, particularly with the exception of injection site reactions. You can see what sort of things people had. Like I said, the decreased creatinine clearance was very minor in almost every case, and you can basically ignore that, in my opinion. And then these are some of the other things people had. So they, and remember, these are adverse events. They're not always linked to the drug. You can't blame the drug for all of these. These are just whatever anyone reported. So, for example, upper respiratory tract infection. The drug didn't cause that, but they got an upper respiratory tract infection and dutifully reported it as a side effect, which is the way a trial should be. But just to give you, a heads up when you look at these numbers, these are just anything the patient complained about for those 3 years they were taking the drug. It's not indicative of what the drug itself is doing to the person. All right, but again, pretty well tolerated. We know Truvada is very well tolerated in PrEP, and so was Cabotegravir. Really, that's the bottom line. Then there's this question about the oral lead-in dose. So remember, in both those studies, patients had some tablets first to see if they were tolerating, and then they moved on to the injection if they were looking well. Now, that's not probably going to be practical in the long run. And so it's currently being studied. There's a protocol amendment in at least the 084, I know, study. I'm not sure about the 083, probably, I'm not sure, where they're looking at omitting the lead-in dose and just starting straight away with injections. And it's important to realize that in that leading dose, they didn't seem to see any signals to suggest you really needed it. Most people tolerated it fine. There were no big differences in whether you tolerated versus Cabotegravir versus PrEP, versus Truvada, sorry, I keep saying that. So it didn't seem really like you hugely needed this lead-in dose. And in fact, the FDA suggests that it's optional in their guidelines. They say, don't mind whether you give a lead-in dose or not. If the patient's anxious and wants to try it that way, you can. If not, just straight with injections. I think pragmatically, it's going to be injections straight, in my opinion. I don't know whether we even have the oral drug coming in the country. I'm not sure, but I think practically it'll be straight to injections. And I think the trial data is reassuring, although it would be nice to have more data in people who didn't start that oral lead-in dose. So that's one big thing to think about. And then how do you monitor for these things? Well, the nice thing is it's so well tolerated, Cabotegravir. It's a bit like dolutegravir. It doesn't really cause kidney or bone issues or liver issues or full blood count issues in terms of your hemoglobin or platelets or anything like that. So you don't need to do any routine blood chemistry tests or hematology tests at all. You really only need to be checking for HIV, and that goes for any form of PrEP, whether you're doing Truvada or whether you're doing this Cabotegravir. You obviously want to make sure that the person doesn't develop HIV, because we know none of these are 100% effective. And if they develop HIV, clearly you want to put them on triple therapy, not monotherapy or dual therapy in the case of Truvada. So that's really the essence of what you need to be monitoring. Now, the FDA suggests check at baseline, makes sense. Check at 1 month, check at 2 months, and then every 2 months. When they come in, basically every 8 weeks for the injection, you do an HIV test. But they suggest a viral load for the reasons I mentioned. Just seems to work a bit better. Now, I don't know what this will be in a local setting like here, because I think we have to be pragmatic a little bit about it. Adding a viral load all these times is expensive. And one public health approach, which a friend of mine actually mentioned today, it was a very good idea, is to say, well, look, of all those thousands of people, very, very, very few of them, only 4, developed HIV despite taking their medicine as well. So in other words, but after they got injections, if they took the injections every 8 weeks, out of what, 5,000 to 6,000 people, only 4 people actually developed HIV. So what you, and if they took their medicines well, obviously if they start missing doses and things, that's different. So what she suggested actually, which is a very clever idea, is maybe you could limit it from a public health perspective, let's say in the state sector, for saying, well, we're only going to do viral load checks if you are, if you miss a dose, say. If you're taking it well and you're otherwise well, we'll just plow on and you can do an ELISA or a rapid. And I don't know how this will settle. I think it's something to consider, it's something to start thinking about, but this is one of the issues about monitoring. If you do want to check HIV, and I think you do because the person's on PrEP, you want to know if they seroconvert because you don't want to leave them on PrEP. How do you monitor? And unfortunately, the best way seems viral load here, unlike Truvada, where you could get away with the ELISAs and the rapids. As being a good doctor, you should always check other sexually transmitted infections as well when they come in. So it's a good point, just as a general practice when they come in to see you. All right, so you've got a kind of a sense for some of these nuances. What about pregnancy? Well, in the study in women in the OH4, you basically couldn't, if you became pregnant, they took you off the injection and they gave you Truvada. to lead you on the tail. So we really don't have a lot of data in pregnancy. There are, again, one of the protocol amendments with 084, as I understand it, is to include pregnant women now. So we'll get more data, but we don't have a lot of data at the moment. And that's going to be, as with so many studies, a little bit of a, it's going to be a hole that we have in our data in terms of knowing how well it will be tolerated. I mean, if you put a gun to my head, I don't think it makes sense that you would particularly have to worry. This is not a particularly teratogenic drug. There was a worry because of the neural tube query about dolutegravir, I think. But I think especially dolutegravir has more or less sorted that out. And I don't think there's a particular reason to worry in pregnancy. It'd just be nice to have some of the data. Of those people who did fall pregnant in 084, there didn't seem to be any problems, although they did take them off the drug afterwards, after they fell pregnant. What about weight and age? Well, it's really for people who are 12 and up and 35 kilograms or more. No data under those thresholds, but you can imagine this is preventing HIV. You hope that you don't have to study a population below these thresholds to prevent HIV. I suppose inevitably at some point you will, but this is clearly not a priority group to be catching children, you'd hope, because this is not the group who, you want to catch people who are sexually active. And I think if you're waiting really to catch people from about 12 years and 35 kilograms, that seems about right. But just to flag it that we don't have data below those numbers. How do you inject it? So this is quite fun. You're meant to use what's called the ventrogluteal site. So some of you will know this already, but if you don't, basically what you try and do is you put your opposite hand on their hip. So this patient's got their right hip facing us. So we're going to put our left hand on the hip, and you put your thumb around sort of towards the crotch, but on the anterior superior iliac spine, so that kind of notch anteriorly. And then, sorry, I beg your pardon, on the, towards the crotch or and over the graded canton, and you put your index finger on the anterior superior iliac spine, that notch at the top, and then you just spread your middle finger in a V, and then you inject between the V, basically. And if you do that, you hit the right spot because it's well away from any nerves or blood vessels or anything like that. There is another site you can try. You might be more familiar with this anterior, so the upper outer quadrant, basically, the dorsogluteal site. So if you're looking from behind at the patient at the gluteal region, if you divide it into quadrants, it's the upper outer one. That's also a safe region. This hasn't been studied in other muscle sites. It does seem important that we do it this way. In other words, don't inject into the deltoid or something like that where there isn't data. And it's important because, again, this is you really do want this to last the full 8 weeks, and who knows what happens if you inject it in different sized muscles or different amounts or different places. So it does have to be intramuscular, and it is there. And you can obviously swap regions between left and right and between dorsogluteal if you want and ventrogluteal, but that's roughly how you're going to do it. So again, anterior, your index finger on the anterior superior iliac spine with the thumb towards the crotch, and you're putting your hand over the greater trochanter, which is that lump on the hip where you can feel if you push on your own hip. And then you make a V and then you stick it there. Now, this is standard issue. This is not a special site just for this medicine. Many medicines are delivered this way. So if you have a nurse who gives intramuscular injections, that's fine, as long as they are doing gluteal injections, not anywhere else, no deltoids or anywhere else. Okay, what about drug interactions? And again, because this is important, you want people on PrEP. It's a little bit like dolutegravir in the sense that carbamazepine, to some degree, although dolutegravir can cope with carbamazepine, but phenobarb and phenytoin, and in this case, carbamazepine as well, are really contraindicated. So you can't really be on first generation antiepileptics if you want to take this. Rifampicin and rifapentine are pretty much contraindicated. You shouldn't take it either. So if you develop, say, TB and you want to carry on this, you clearly can't give them rifampicin and take cabotegravir. So there's two options. One is you can use rifabutin. For those of you who know what that is, it's kind of it's from the same family as rifampicin, one of the rifamycins, and you can work around it, and you can give a TB regimen that contains rifabutin instead of rifampicin. And then what you have to do is just give the cabotegravir more frequently. So, for example, every 2 months, it will move to every month instead. But I think in that case, to be honest, I would much rather just move to Truvada in that sense. It's much easier. They can happily take that while they take the TB treatment. And as soon as the TB treatment's over, they can go back to the injection. But there is a way, if you really need to get TB treatment, you just can't give them standard TB treatment. You have to move to rifabutin. And then, importantly, the hormonal contraceptions have no effect. I've put them here just to flag it, because many people want contraception at the same time, and maybe injectable contraception at the same time, also say every 2 months or 3 months, depending on what agent they use. And there's no issue with that. You can take them at the same time, and you can they don't interact, which is really, really good to know. What about kidneys and livers? Good news is same with dolutegravir, doesn't matter. So it doesn't really affect the kidneys, it doesn't really affect the liver, and you also don't really have to dose adjust them with kidney dysfunction or liver dysfunction. So it's pretty well tolerated. Then remember, we said you don't check the kidneys and the livers in terms of blood either at baseline or in follow-up, and this is why it doesn't affect them and doesn't get affected by them. So that's useful to know and make sure. And then really the last part of this is just to discuss where I think it fits in. So we've given you a good kind of spread now of what things are out there and what the kind of advantages and disadvantages are, but how does it fit in? Where do I think this might come? And this, again, is my personal opinion. We don't know where it'll sit with the guidelines. We don't even know what it'll cost in South Africa when it comes here. And so there's a lot of unknowns at the moment. But let's just, with that in mind, we anticipate it won't be long before it's around, and we know these answers. So let's just think about where it might fit in. So here are some of the advantages and disadvantages. So we know about that Truvada is a tablet, and there's injection, obviously. And it's a tablet you have to take daily versus an injection you take 2 monthly. Now, I've suggested here, this has got better efficacy than injection, mainly driven by just therapeutic time, about the time that the drug is therapeutic is that much bigger, that much more. But some people really just like a tablet. They don't want an injection. They prefer a tablet, in which case that's great. And the big thing here is that it's not aiming to replace anything. This is really just offering another option on the table for people who would like it. And if you do surveys of opinions, most people, at least hypothetically, who are HIV positive, prefer an injectable that's 2 monthly over an oral tablet every day. And some people describe, for example, the fact that psychologically they feel that they're not sick if they're not taking a drug every day. Their stigma may be a bit less because you don't have to have a bottle hanging around your house that other people can see. But this won't be for everyone. Some people will prefer a tablet. And like I said, if you take your tablet and you stick with it and you like it, it works well. It works really well. So that's still, it's not going to be a replacement. It's going to be an addition, I hope. Efficacy is, again, very good. I didn't give you numbers there, but just very good. So again, in MSM, men who have sex with men, probably around 90% or so. And with women, a bit less, probably 60, 70%. But again, very dependent on adherence. In other words, a woman who takes it every day is going to have a higher efficacy rate than a man who skips it almost every day. So again, very driven by adherence. Cabotegravir just seems a bit better in terms of efficacy in both these studies, but again, that's because of the fact that it's every 2 months and the drug level can hang around. So you don't have to remember to take it every day. Again, if adherence is perfect with Truvada, they're probably going to be the same, but this is driven by the fact that the adherence isn't the same. Safety, both of them are very safe. And I've showed you, like I said, don't get too alarmed when you look at those lists of problems, because like I said, those were just anything anybody had within the 3 years, and they were told to complain about and got to write it down. But really, it doesn't seem like there's any significant issues. The only thing to be aware of with cabotegravir is that injection site reaction, which, like I said, is usually moderate to mild. And there's ways of just taking some over-the-counter analgesia and getting over it. And it does often get better with time as well. It seems to be more prevalent in the first few injections, and after you have had a few, that your body seems to react a bit less. Then there's how often do you have to see a healthcare worker, and that's an important thing as well. So in theory, if you're getting PrEP after, so the guidelines currently would see you after a month or so just to make sure it's all working, but ultimately you can get it down to roughly every 6 months that you would come in, and if you can get a repeat script for those 6 months, you would have to see a healthcare worker only at that point, and that's important because again, that's an advantage potentially to the Truvada setting. Whereas with cabotegravir, you pretty much have to see a healthcare worker every 2 months because you need an injection. It doesn't have to be a doctor, it could be a nurse in theory, but you have to go in every 2 months to be seen. Now, again, some people view that as an advantage, some people view it as a disadvantage, but it is that is an important difference in the frequency, so it's something to think about. And then the cost we know, and again, there's lots of generics to Truvada as well, there's Truvada and generics, and that cost is relatively cheap. It depends on which version you're getting. You in the 300s usually of rands per month, if you're buying them in terms of the SEP. Cabotegravir, we don't know because it hasn't been launched, but it's very likely to be quite a lot more expensive. And so that's a factor to consider as well. Now, from a public health perspective, you can start looking and say, well, it may be more expensive, but it's going to save more HIV infections. And so maybe it's more cost effective. And that is a debate worth having, and people are analyzing that. And some of the local groups have already done some good work in that. But obviously from an individual perspective, it's going to almost certainly be more expensive than Truvada. So that's another thing just to factor in, because you'd much rather they take Truvada than nothing. So if you're giving cabotegravir and they can't afford it and drop off for that reason, much better that they carry on with Truvada. in that setting. So you've got to be cognizant of costs as well. And again, we don't know. We'll have to see what the costs are. So that's kind of in a nutshell where I think it might fit in. And then really, where does it have to go from here? And others on the call may know more about this actually, because I don't have a particularly close to the ground in the setting. It has been FDA approved now in America as of December last year. That's really good news because that often accelerates a lot of other regulatory authorities which can use a sort of reliance mechanism on the FDA, because the FDA is a very good authority. So, for example, SAPRA may be able to at least rely on some of their work to speed up the process. SAPRA, as I understand, have received the dossier and it's pending. So in other words, being processed. So we don't know when it'll be processed, but if it does come out, if SAPRA is approved, then it'll be approved locally here too. It's in the process. Department of Health is looking at evidence reviews currently and looking at the cost effectiveness and the total budgetary cost and all of the things that go into it. So I can't predict the outcome of that, but it's certainly on the radar. So we'll have to see. WHO is preparing guidance on this. Again, probably in the next couple of months, WHO will come out with guidelines on this. And that will also be very interesting because WHO are quite cognizant of the low and middle income setting which we're sitting in. So that'll be good, and it also may cover some of the practicalities of that. For example, do they recommend an oral lead-in dose? What sort of monitoring do they recommend, bearing in mind that viral loads might be quite expensive? So it'll be interesting to see what they decide. I don't know what they'll decide, but we'll watch the space and we'll see. And then finally, really, just to look at this, like I said, I think this is one of many options, and we haven't covered the Prophylaxis ring at all because it's new and it's coming. That's for another day. And I'm sure, as you've heard tonight, there's more than enough for just Cabotegravir alone. But there will probably be a bunch of options soon for people in terms of pre-exposure prophylaxis. So there will be the oral tablet, a combination of tenofovir and emtricitabine in various forms. In South Africa, there's also TAF and FTC overseas, although not locally. There's Cabotegravir. Well, we do have some here, but it's Cabotegravir, which we've described for most of tonight's session. And you can see already that appears to have an efficacy advantage. But again, will not be for everyone. There'll be some people who just don't like it or don't want it or prefer different regimens or have contraindications to it. For example, they're on TV treatment. So there just needs to be other options. And then the Prophylaxis ring, so vaginal ring, which Prophylaxis in it, which also has efficacy, although lower than Cabotegravir apparently, although no direct head-to-head trials. So I think the idea behind this really is it's going to be one of a set of options that people will have before them, and a little bit like birth control, because there's not one option for birth control. There's multiple options, injectable or implantable device, or many different options. And it's similar sort of idea in terms of pre-exposure prophylaxis. Oh, I've gone too far. Sorry. Go back one. There we are. And this is really part of this. This is a slide from Mike Cohen, who's a professor at University of North Carolina, who's done more work than most people in their lives in terms of preventing HIV. And this is really the kind of spectrum of things we can do to prevent HIV. And this is everything you can do to prevent HIV. So there's behavioral and structural things that you can get right. And that includes, for example, circumcision and condoms. And then what can you do for the exposed person, either pre-coital or coital? So this is where the time you're going to give pre-exposure prophylaxis. And we've talked about some of the options of that tonight. There's microbicides as well. And then vaccines somewhere down the line. There is already a slightly effective vaccine, but we clearly need better options for HIV. But this is the sort of things which you could do to prevent HIV. Because if you want to end HIV, it's got to be something on the slide. But it won't be one thing on the slide. It'll be multiple things on the slide because it's got to all work together and they're not mutually exclusive. Again, what about people who've been exposed after sex? So, for example, who've been exposed, and then what can you do after sex? Again, vaccines maybe down the line. Maybe that will prevent you there. What about post-exposure prophylaxis? And that's, again, topic for a different day, but you're all familiar with that, what you do if you get a needle stick or something like that. And then what do you do if you're infected? So could you reduce HIV transmission by treating people? And Mike Cohen showed this very well, that U equals U, right? So if you get the viral load down of the infected person, you're going to have less chance of transmitting it to the next person. Well, and if you get it right down, of course, you have functionally zero chance of transmission. So this is the spectrum. And if you want to be part of ending HIV, you've got to be promoting as much of this as possible, because all of this works. And it's a bit like Swiss cheese in the sense that no one thing is enough. But if you start doing multiple of them together, you really can make a big dent. So what we concentrated on tonight was the PrEP aspect, really looking specifically at Cabotegravir. But you can see it's part of the spectrum. And it's something just to bear in mind when we do it. We do this part reasonably well. We give post-exposure prophylaxis pretty well because people are very concerned and they come in and they get good care. Most of us who practitioners don't do PrEP well. And that's something we can get a lot better at. There are already HIV Clinician Society guidelines on the oral PrEP, and I encourage you all to go onto the website, the HIV Clinician Society website, and look at them. And if you're not making part of your practice, if you're seeing people who are HIV negative and your practice is a routine thing, you really should be considering this as one thing that you can be adding. And then today we talked about an exciting thing, which will be here soonish. I don't know when, but soonish, where we think we'll have another option in terms of PrEP. So I'm going to leave it there. Thank you very much, Nseko, but I'm very, very happy to take questions. I see there's a bunch of things that people with their questions up. Thanks very much.
Thank you. Thank you very much, Jeremy. This is really appreciated. There was a number of comments and questions on the chat, not necessarily on the Q&A, but I've summarized some of them. So maybe we can just go through them, and then in between, I will take hands as well. So there was a number of questions or comments as to why we have low efficacy of either of these modalities in females. Is there a specific scientific reason why?
Yeah, it's a really good question. So I think the difference is biological, because I don't think women in any other setting on average take pills worse than men. So I think the difference for oral tablets is biological, and we do know that it takes longer for the oral pre-exposure prophylaxis, the TDF, FTC, to achieve therapeutic levels, or what we think are therapeutic levels, in the genital tract. And that's clearly what you want. You want it to be, because it's not, you're not trying to treat the person who's got HIV where you want it to be therapeutic in the blood. You want it to be therapeutic at the genital tract to prevent them getting HIV. And we know that with men, for example, just taking it for a few days can get that level up to protective level, whereas for women, it takes a couple of weeks to get up to that level. So for example, and someone's going to correct me because I'm going to get this a little bit wrong, but I think for men, it's 7 days that we recommend, and women it's 3 weeks, I think, something like that, in terms of when you can consider yourself protected once you start taking the tablet. So I think the fact that it gets therapeutic much quicker in men probably accounts for some of the better efficacy, because it means that if you're skipping doses, and if you're both skipping the same amount of doses, you'll just get back up to therapeutic levels that much quicker with men. So you're protected for much more, whereas women have to be much better to achieve the same genital level. So I think that's probably, there might be other reasons, but that to me is a big one. The interesting thing about Cabotegravir is that we saw the reverse. So the women actually had a better effect difference compared to Truvada than the men. Now, whether that's because Cabotegravir was just better in women, or whether it was just because it wasn't Truvada, which is not as good, in terms of that. So, but it does appear actually that Cabotegravir gets to the vaginal mucosa a little bit better, interestingly, than the rectal mucosa, for example. So there might actually be a biological reason for that in reverse. It might be slightly better for women than men for that reason, also biological. But again, I don't want to overplay this. This is somewhat speculative, and clearly it's very, very effective for both sexes. I mean, it's not, you don't want to say it's better for, it's not like it doesn't work. I mean, it works wonderfully for both groups of people. But there probably are small biological reasons to account for some of the difference, in my opinion.
Sure. Thanks for that. So as a follow-up linked to that particular discussion, it's the question of, in terms of Cabotegravir, how long does it take to reach the therapeutic levels?
Yeah, it's a good question, and I don't know. I did read this a while ago, now forgotten, so I'm not going to give you any lies. But basically, you are regarded as protected from your second injection, basically. So somewhere between your first and second injection, you're going to achieve it. But as a practical point from the FDA side, for example, by the time you achieve your second infection, usually that's regarded as enough, because now you're up to therapeutic, but probably before that. I don't know when it peaks in the genital mucosa. That's a really good question, and I just don't have a good answer, I'm afraid, for that. But again, it's not going to be long, and it's, the level, the peak is not long. The tail is very long, but the time to get to the peak with Cabotegravir with injection is not particularly long. So you should be therapeutic, pretty soon, long before your second injection, in fact.
Superb. I see Dr. Modi is talking about, when you presented the side effects, there was some sizable number of patients who experienced liver toxicity. Now he's trying to understand, it's not something that we understand in terms of TDF and FTC. So what was the source? Or
let me just see if I can share it. Hold on 1 second.
Slide again. Yeah.
No problem. Yeah, no problem. I'm going to pull it up. let's look at this one. I think that's a good one. So let me zoom, sorry, and then share.
Sure.
Okay, so this one. So they're looking here.
Sure, thanks.
This bottom one is a liver-related adverse events resulting in discontinuation of both of them. So you're quite right. They looked at the liver, and cabotegravir, like any integrase inhibitor, can very occasionally cause liver problems. We know, but if we think of dolutegravir, we don't regard it as particularly bad for the liver. But if you look at the package inserts, it's under 5%, and maybe 2 to 3% of the time you can get a hepatitis for that. So it's worth looking at. And as you quite rightly said, we don't regard Truvada or any of the generics of it as being particularly hepatotoxic. But the interesting thing here is if you look at the numbers, it was 2 and 2.1% of both. So remember how the study is designed. Anyone with any liver problem in the 157 weeks is going to be counted. So it's not saying it's from the drug, but the interesting thing is you can see the difference between the two is basically 0, which implies, because we know that Truvada doesn't really do it almost ever, it implies that cabotegravir really wasn't doing it either. So don't look at the absolute numbers as 2%. It's important rather to look at the difference and say, was cabotegravir causing it? No, it wasn't. It's very, very safe in terms of the liver.
Great stuff. Now, there was a question on ethics as well. Was there at any point where participants received placebo, a pure placebo? And what are the ethics around that? Though I got a different understanding, but there was a question related to that, yeah.
Yeah, sorry, it's a good question because this trial is quite hard to explain because of all the various placebos. But in answer to your question, no one got a pure placebo. So you either had at any time Truvada or you had cabotegravir, either orally or injectable. And you had one of those two at any time. You just didn't know which one it was. And because they wanted to keep you blinded, they had to give you a placebo in addition. So if you got, let's say, cabotegravir injection, then you got oral tablets which were a placebo to look like Truvada. Whereas if you got Truvada, then you got an injection that was a placebo. But you always had one active drug, no matter, it was, and you didn't change between the two, obviously, unless you had to stop for side effect reasons. But no, so all of these people always got either Truvada or cabotegravir. The reason for the placebo is just to make sure that they couldn't tell which one it was. And nor could so you got an injection placebo if you got the real tablets, or you got the tablet placebo if you got the real injection.
Great stuff. Now, in the TDF-FTC, the current national guidelines, there's a recommendation that if a patient wants to stop, you should continue the PrEP at least for 28 days from the last exposure, sort of an unprotected setting.
Yeah, right? I think, yeah, so I think what that refers to is...
yeah. I wanted to understand stopping for cabotegravir. What is the best way to stop in that context, but also in terms of, do we need to cover the tail, or how does it work?
Yeah, so that's such a good question. So I think in the oral PrEP, I mean, you can just stop, but I think the question is about what if you have a high risk exposure? So if you have a high risk exposure, let's say last week, and you want to stop pre-exposure prophylaxis, then you should carry on. You should still have some coverage in terms of post-exposure prophylaxis for that for about a month afterwards. But so what would you do if the injection was here? So if you stopped, it's going to work for 8 more weeks, certainly, because we dose this every 8 weeks. So you covered for the next 2 months. The question is what to do after that period when the level starts getting lower and lower and lower. And if you're not at high risk of HIV, that should be fine, because you shouldn't expect to catch HIV in that post, in that long tail period. But clearly that's going to be an issue, right? People do move between high risk and low risk environments. They not sexually active, then they become sexually active, or they change, boyfriend or girlfriend, and it becomes a different risk scenario. So I think that's going to be difficult, and that's going to be something to navigate at an individual level. But certainly after you've taken the last injection, you're good for at least 8 weeks, and probably longer than that, to be honest. And then the question is, what do you do about the tail after the 8 weeks? And that is, like I said, that's a difficult one, because here, what they did if you had a tail was they gave you Truvada as well, so that you were covered. And I think that's certainly an option you could do. If you need PrEP, but you just don't like the injection and you want to move to tablets, that's easy. We just move you to tablets. But what to do if you don't want anything? Well, then you've got at least 8 weeks of effectiveness, and after that, you take your chances. So hopefully you don't need anything at that point. But I think it's, I don't want to oversell it too. The tail didn't look hugely terrible in any of these trials in terms of getting HIV. It did seem to at least have partial efficacy and didn't seem to drive resistance, which is surprising, actually, to me. I thought it would, but it didn't, at least in these trials.
Superb. Now, I mean, I'm just clustering some of these questions. There was a number of questions around the models, home care, pharmacy injections. I mean, what are we looking at in terms of possible models? Yeah, for
another
access.
wonderful question, and that's why I wanted to give this talk now, because it's time to think of those things, and I think the answer will be different depending on your setting. You need an injection here. You don't necessarily need a doctor, although you need to be part of a system that is not just giving an injection. For example, we do want you to check for HIV. We would ideally like to at least ask about STIs, and if not, screen for them. So, PrEP is not a wash your hands obligation, and walk away. You do have to be plugged into this. And so how does that work? That's going to have to be individualized. Now, in the state sector, the answer may be different from a private sector. Hospitals may well be very different from clinics, and GP practices may be different from specialist practices. It may be, and it's difficult to get right. But it is just worth remembering that, this is worth thinking of, but this is not some problem we've never come across before. I mean, we know, for example, what do we do with 2 monthly injectables, for contraception? We have this problem all the time. Or what if you come in for 6 monthly injections for a variety of things, variety of metabolic things, or you're coming in for your annual injection for this or that? There's ways of doing this. It's just that we have to consider how to do this. Remember, these are HIV negative people. These are healthy people. And you don't need, if you're using cabotegravir, you don't need to be doing blood monitoring other than HIV. And so if you're building this into your setting, in whatever setting, but you're absolutely right. I mean, we have to think about it now, but that's why I wanted to do it now, so that people can start thinking of their own setting. How would you build this into the setting if this was available to you? And the answer is going to be very different at different settings. But it's not impossible by any means. I mean, this is just an injection. We do this for many types of medicines, many types of diseases. And we just need to work out how to do this with people who are well, remember, because these are preventative injections. So you're not dealing with a patient who's sick, you're dealing with someone who's very well and wants to stay that way.
Great stuff. Colleagues, please, I want to take a few hands. So if you do have a question you want to raise, you may maybe raise your hand. Dr. Shakes, you had a number of questions that you wanted us to clarify. Would you like to maybe unmute and say something around some of the questions you had? Dr. Modi?
Yes, hi, Jeremy. This is Shakes here from Right to Care previously.
Sure. Hi, Shakes.
Hi. Tell me, is there any class resistance with cabotegravir, with like dolutegravir? Because if so, then when this drug is introduced, then we will in case there's poor resistance, do we have to do resistance testing for dolutegravir?
So I would certainly do integrase gene resistance testing if a patient develops HIV on cabotegravir, and that will look at all integrases as one test. But yes, there is a lot of cross resistance between cabotegravir and dolutegravir. So it does depend on the particular mutation, but certainly if you do get cabotegravir resistant, you may well knock out dolutegravir too. But I think, if someone was on the injectables on cabotegravir and they were getting it and defaulted, for example, and then they develop HIV, that's a very important time to be checking integrase resistance testing without question. And again, that will be a very rare scenario based on the trial, but that's, you can't assume that if someone develops HIV on cabotegravir that it'll be fine to give an integrase inhibitor. But just to make the point that it's not inevitable on the other side either. I mean, most of the people who developed infections on this regimen did not develop integrase inhibitor resistance. So you just can't know. You have to check for it, but it's not inevitable at all. Quite the opposite. In fact, the majority of people don't develop integrase resistance, even if they develop HIV on an integrase inhibitor.
You mentioned that there are few infections during the tail period. Very few, but could that be because the patient had some other risk factors such as genital ulcer disease or so forth?
I don't know. It's a good question. They did look at sexually transmitted infections over the trial and didn't see a big difference between the two arms, but that doesn't quite answer your question. I don't know. I mean, but I think it's just the fact that you've stopped taking the injection makes sense that you would be at risk of getting HIV, because obviously the drug level is lower and lower each day. So you might not need an extra explanation for that, but they could well have had STIs as well. I'm not sure, and I don't know that the data is in the published paper, although the investigators may know.
Okay, one last question. The clinics are really clogged up at the moment. The nursing staff do not manage. So if the nurses are taught how to give injections and they go to the patient's house and give the injections to patients, Is it not possible to, so that the clinics are spared from, overloading?
Yeah, so could a nurse give this injection? I mean, sure, I would have no problem. And again, I can't talk for what the regulation will be around it. That we still have to discover as a country what will be allowed, what not allowed. But from my perspective, it makes all the sense in the world. Nurses, we know nurses can give injections safely. They do a better job than the doctors. So there's no reason why this medicine would be any different. This is not like a flu vaccine where there's anaphylaxis and you've got to watch. For all COVID vaccines, you've got to watch nervously for 15 minutes or anything. This is really just, give and forget. So absolutely. I mean, I think that's the sort of thing that's well worth thinking about, is how would we get these injections to the patient? Just remember, though, that part of this 8 week, every 8 weeks of getting an injection, it's not just about the injection. Ideally, they should be checking for HIV around these times. And again, we don't know what the guidelines will eventually say, how frequent to do it. But, this should be at least paired with, say, taking a blood sample occasionally as well to check for HIV as well. But again, a nurse could do that too. Whether you do it like the FDA says every 8 weeks, or whether probably in South Africa it might be a bit less frequent than that, we don't know. But that's something to consider. So it's not just the injection, it's also checking for HIV, although we'll have to see how frequently that's demanded in the guidelines.
Okay, thank you very much, Jeremy, for a fabulous presentation.
Sure. Thanks, Shakes. We always have the best questions.
Thank you. Let me see, Willie Mpia, I'm not sure if your hand is up by chance, please lower it. Willie, would you like to unmute and ask your question? Willie Mpia? Please unmute if you have a question. All right, I'm moving on to Tuli.
Okay, no problem. I see Dr. Mpia's put something in the question in the chat. I don't know if you're just asking about, can PrEP and Cabotegravir in particular be a better approach for, let's say, yes, people who have some degree of mental retardation and they at risk of sexual abuse in the community. I mean, I hadn't thought of that aspect, but I think that's a really good thing to think about. I mean, you'd have the same consent issues as with anything, but if, for example, the person's not able to consent, if they're that, if they have that difficulty with the mental challenges, or if they are able to consent, I mean, I do think this is the sort of thing to think about, and there is potential for that here. It may be far more feasible to give a 2-monthly injection to that sort of person than to try and get them to take tablets every day. It's obviously going to be very individualized for the patient, but it's a good thought.
Great. Mutibedi, you may unmute. Lieketseng, Mutibedi, if you have a question, please unmute. All right, I'm not sure if these hands are real hands, so I'm going to lower all those hands. Yes, the other key question was, in terms of Cabotegravir, is there an option to use is there an oral version of a Cabotegravir as an alternate to the injection, or it will be?
Yes. No. So there was there is an oral Cabotegravir that was used in these trials as the oral lead-in phase. So you can see either oral Cabotegravir or that. It's not been studied though as a permanent PrEP like Truvada as a tablet form. It's really just used in the lead-in phase for the injection. So to be honest, I'm not sure if the oral version is even going to be registered here. I don't know. Maybe someone in the audience knows. Can type in the chat, but. I don't think it's really being studied as a long-term version for oral form. It's just really as a lead-in potential for the injectable form. The injectable form is really the focus for PrEP.
Superb. And then the issue of HIV testing, ELISA versus viral load. There was a question as well to say, can you clarify further why not an HIV test? And I think Rochelle as well was saying, what about the HIV self-testing and in this context, but I think it's more the reasoning behind why a viral load.
So it's a good question, and I don't know that we have the entire answer, but what I will say is clear from these studies is that let's have a look at this group D. Now, I don't have the exact right image, but we can use this one. In this let's say red diamond is when HIV was detected. So here around just maybe 19 weeks or so with number 4. This one looks like about 18 or 17 weeks. This is somewhere in 26 weeks, let's say, and this is about 55 weeks, roughly, right? That's roughly when they're done, but they were tested by ELISA at every visit. And so they got tested here in the injections as the circles. They got tested baseline, they got injected here, 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 and they go on and they get tested every single time. But what they found rather when they did this test is that many of them tested negative, 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 and then eventually positive. But then when they went back and analyzed their blood samples from those first few visits or from somewhere in an earlier time point, if they did a viral load on those, they detected HIV. So in fact, the HIV was present for a long time before the ELISA turned positive or the rapid test tested positive. So that's just a fact in the sense that, for whatever reason, these tests are delayed in their turning positive, the ELISA and the rapid, whereas the viral load detected at closer to the right time, right in the beginning. Now, why that is a matter of debate, but it probably is the fact that you still have cabotegravir suppressing the viral load a lot, even if it's not perfect. And so that viral load is so low that you don't get a big immune response to it like you would if you got HIV sexually. Because if you get HIV sexually, 2 to 3 weeks later, your viral load might be 1 million, 10 million. Whereas here, the viral load is, 10, 100 to 1,000 because of the cabotegravir, hanging around. And so probably that's what's leading to the delayed time it takes to find this by ELISA and rapid. So that is a concern with this sort of thing, because you don't want HIV people being HIV positive and not knowing. And that's the trade-off. Now, if we do a viral load on everyone, we'll detect it earlier, but it's very costly. So you've got to have the kind of trade-off. And we know it's not common as well to have breakthrough infections. I mean, these work so well that, that there are very few people who are going to get HIV. And then maybe you could limit it a bit further. You could say, well, I'm not going to do a viral load unless you default your medicines or unless you miss a dose or something. And then we can test those. And then you're just left with only a very, very small number of very unlucky people who did everything right and still got HIV, and you missed it for a while because you relied on ELISA. So it's a trade-off. If we want the earliest possible detection, it's got to be viral load. But if we, in a public health sector, and when we don't have unlimited money, maybe there's ways of finding the optimum trade-offs where you get the most bang for your buck without bankrupting the state. So it's something to look at. And I don't have the answer. I'm just flagging the issue, really. And that's that, unfortunately, it appears that the ELISAs and rapids take a long time to turn positive after you get HIV, if you do get HIV, when you're on these cabotegravir injections.
Thank you. I think that is quite clear. Tabile is interested in the vaginal ring, and she's asking, is it now in use? I think you did reply to that. To say, but I'm not sure.
So not really. It's been studied and it's got some degree of efficacy. It's a topic for another talk maybe, but it's not around yet, but it's coming and it will be very, very soon. So it'll be another option. And again, these are not mutually exclusive. You could have one partner on a vaginal ring and the other partner getting cabotegravir, for example. There's so many options, or you could presumably get both, although I'm genuinely not sure if that's allowed, but there's lots of options. So it's not around, it's not prime time yet. It's not, you can't walk to Clicks yet and buy it, but it's coming, and it will be another exciting thing to have around as options for people. Every little bit helps.
Great. 2 more. So this is the second last question. It's around cabotegravir and pregnancy. Should we be worried? What does the FDA say? I know you had a slide on it. But do you foresee the injection being suitable in pregnancy? Are there any immediate concerns, or what's your? We know dolutegravir is safe in pregnancy. Should we presume that it's likely to be safe as well?
Yeah. So let me find this down for you here, because I'm looking at on my app as we talk. There we are. It doesn't have a pregnancy class, but so the issue really is that it's not well studied in pregnancy. I mean, I can give you the answer that way. So it's because of these studies in the 084 study, which was in women, where if you weren't allowed to be pregnant at the time, and if you became pregnant, then you were moved on to Truvada. So the issue is really we just don't have a lot of data in this. Now that's being remedied because 084's got a protocol amendment which is now including pregnant women. But I don't, hand on heart, I don't think it'll have any problems at all with pregnancy. I just think it's a question mark because we don't know. But the integrase inhibitors are safe in pregnancy. I don't anticipate it'll be a problem. I just think the issue is, will the guidelines when they come out, will they be happy giving it to pregnant women without the data to show it's safe? I don't know. We'll have to see, but maybe not, which is sad. But hopefully we'll plug that research gap soon.
Superb. Kenny is talking about something, so I just wanted you to clarify. PrEP with condoms, PrEP without condoms, are we getting the same results?
Yeah, so it's a good question. Remember, all of these methods here, like Cabotegravir, they protect well against HIV, excellently against HIV, but they don't offer any protection against other STIs. And so in general, if you are worried about getting HIV, you should be worried about getting other STIs too. So the general guidance for most instances of PrEP, and again, this may be tailored. For example, maybe you are in a serodiscordant relationship, for example, where you have one partner for many years, and the only risk is HIV. Okay, so then that's a different answer. But for most people, if you're at risk of HIV, you're also at risk of other STIs. And so the general advice is to use condoms as well, or some form of barrier protection as well, to prevent mostly the other infections more than the HIV, although obviously it helps HIV side too.
Yeah, so the closing question from myself, Jeremy, the minister. So what do you think will be the uptake in South Africa? And maybe based on your experience in terms of the vaccination program, what is the prevalence of needle phobia? I don't know if there's such a, a term.
So it's a good question, and a lot's going to depend on the rollout if it happens. And again, I mean, we don't even know. Again, the state may find it too expensive and not do it for all we know. But let's say it gets rolled out, it's available. The rollout, as you rightly said, is everything. If we get this messaging right, it will be really helpful. If we get it wrong, it's going to be a waste of money. So it really does need to be an essential thing. But I do genuinely, there's two pieces of evidence we have that it might be a lot better than PrEP, because the oral PrEP at the moment, the uptake is not good. In a country with so much HIV happening, so many infections happening, we should have we should be far more people on oral PrEP than we have. So why might this be different? Well, one is that when people are surveyed, and again, there's different surveys, but on average, most people seem to like the idea of an injectable in a way that they don't like an oral tablet. Because remember, if for PrEP, these people are well, you take an HIV negative person and you ask them to take a tablet every day. That's a tough sell sometimes. Whereas if you can come in and get an injection every 2 months, people are much more likely to do it. Also, you can schedule it, you can have a date, it's a much less forgettable thing, and you can have follow-up appointments. And if you miss it by a day or two, it's fine. You can, it doesn't matter hugely because of the long tail. So people tend to want it. If you survey them, they tend to be much more excited about this than a tablet on average. But again, people are different, but on average. And then the other thing I think is that there is a real issue about stigma of this. If you are walking around with these tablets in your purse or your wallet, or not your wallet, but your briefcase or whatever, your bag, it's a sign to some people, and I do not agree with this, but it is a sign to some people that perhaps you loose, or you're sleeping around or something like that. And again, that's a really unfortunate interpretation, but it does happen. It's a reality. And so the ability to get an injection, say, every 2 months may well help a lot of people in that way. Plus, it can be monitored a bit more. And to be frank, some of the teenagers, maybe their parents will bring them in. Even if the teenagers don't want it, maybe the parent will say, right, let's go. It's your 2-month injection, in a way that they have far more kind of parental oversight than if it was a tablet that had to be swallowed every day. So I don't know. I'm guessing like everyone else, we don't know what it'll be like here. In America, the uptake has been good compared to oral tablets, but its early days, was only approved in December. So we'll have to see, but I really hope it is. And again, whether it's oral PrEP or whether it's Cabotegravir, I don't mind. But as long as more people are on it, I think that's the big thing, because we have so many infections we need to be preventing in South Africa. And there are ways to do it. And we've seen some of them tonight. So hopefully people do take it up. I hope. Cross fingers.
Thank you very much, Gerald. I see Pembe Lalamani says, thank you very much, Dr. Nel, for an excellent presentation. Very promising drug. People are tired of daily tablets. So we hope the day comes where we really, launch this particular program, and hopefully it will be well planned, because it seems like if we get the planning right, we might win. But if we rush things, we might end up a little bit, with more challenges. So yes, Jeremy, thank you very much, for availing your time. This was very insightful. I personally learned a lot from this particular topic, and I can see, based on the comments from everyone in the chat, that it was quite time well spent developing ourselves. So thank you very much for that.